Should be 12 people on. Wonderful. All right, we'll get into it. So can everyone hear me online? I think have I given access there? Wonderful. Thank you. Fabulous. Thanks, everyone. So thank you for joining us today with Dr. Grace Phua from the Syphilis Response Team at Boorloo Public Health. We're going to be doing a focus on congenital syphilis today. And before we begin, I would just like to acknowledge the traditional custodians on the lands on which we meet today. We're meeting here on Wajak Noongar, and I'd just like to pay my respects to elders past, present and emerging. And I'll pass it straight over to Grace. So thank you so much, Grace.
Thanks, Liberty, for this invitation and for the opportunity to speak with all you fine people today. I know that you guys are all working in various capacities around the state. I'd love to know what some of your roles are. Maybe if you just pop them into the chat as I start my presentation. I'm just going to share my screen. Okay. So hopefully you can all see that. My name is Grace. I am a GP. I work on the syphilis response team at the Boorloo Perth Public Health Unit, and I'm involved in the Syphilis in Pregnancy program as part of that. So most of you don't need introductions to the way public health is run in our state. You would have a public health unit for your particular region, and our public health unit just covers all of Perth. Again, part of our role in public health is to do the kind of public health actions following a notifiable disease. So syphilis is a notifiable disease, as are, more than 80 other diseases that clinicians and labs have a mandatory kind of requirement to notify, so that we can have an overview of what's happening with that disease and also make sure that we're trying to protect the public from it. So we're talking about syphilis today. How on earth is there a syphilis epidemic in 2024? Wasn't this disease done and years ago? And actually at one point we thought we might be, sort of clearing free from it, but unfortunately it's come back, and it has been a problem in Australia as well as a number of other developed countries around the world. So I've taken some data from the WA Notifiable Infectious Disease Dashboard, which is a publicly available website, just to show some of the rates in the different regions. Those of you who are working in the regions, this is obviously not news to you, but we have seen syphilis in terrible rates in our Kimberley, Pilbara and Goldfield regions for some time now, although it has been quite promising that we've seen a decrease in those rates more recently. Now, if we take out those kind of highest rates and look further south in the state, we can see that even though it's decreased a lot in those states, we've seen some increases, particularly in the Midwest. We saw an increase in Perth, which is also, sort of turned around a little bit. Some increases in the Great Southern. So, we're certainly not clear of it. This is looking at the rate by Aboriginality. It's terrible graph, obviously showing that it is so much higher amongst Aboriginal people, although hopefully that is continuing to drop as it has been in recent years. And just zeroing a little bit into Perth, where I'm based, and where it kind of gives the context for a lot of things that I'll be talking about. So you can see that it was almost non-existent prior to 2000, and we can see a slow climb, firstly in the men who have sex with men cohort, and then moving out of that cohort really into priority and vulnerable populations such as our Aboriginal people. So almost Didn't see it in Aboriginal people in urban areas previously, people experiencing homelessness, people who use drugs, and into women. So previously very few cases in women, and now cases in women make up about 1/3 of all of our notifications. So a quick overview of syphilis. This is nothing groundbreaking. It's available in all of your medical textbooks, but it is worth going over just to remind ourselves of some of the ways that it presents, noting that it often presents in atypical ways. So this is what syphilis is often associated with, this primary chancre, single, painless, indurated ulcer, but we know that actually it often doesn't present that way. They can be multiple ulcers, they can be quite painful, and they can be mistaken for other things such as herpes. That can resolve spontaneously even without treatment, and then a few months after being exposed, people can develop more constitutional symptoms. So they may get some sort of cutaneous manifestation, whether it's a rash, whether it's some sort of patchy hair loss, whether it's some patches in mucous areas like around their mouth or around the kind of genital region. They can also get neurological involvement, so they can get cranial nerve palsies, any part of their eye can be affected, they can lose their hearing. So it's a bit of a misnomer that neurosyphilis only happens in the late stages. That actually can happen at any stage of syphilis. And if they don't get treated for that, many of those symptoms will also self-resolve, and then people can slip into this latent stage in which they have no symptoms at all. They are, however, still infectious in the first 24 months of having the infection. And then curiously, syphilis can slip into this latent stage where it becomes non-infectious altogether from a sexual point of view, and people can go on and have latent syphilis for the rest of their lives, really. Some people will then develop complications down the track, kind of serious complications involving their skin or their heart or their neurological system. But some people, will actually not have any issues at all. So that's how we divide syphilis into those two stages, the infectious and the non-infectious stage, noting, of course, that the non-infectious stage is still transmissible to a fetus from a pregnant person. So it's important to go through, the clinical course, because it's important for our healthcare workers to be thinking again, have I excluded syphilis when they're working up a patient? So, when you're looking at ulcers, when you're looking at genital lesions, if you're looking at an illness that you don't quite know what's going on, there's some weird lab results, unexplained, perhaps strange LFTs, liver functions, a rash that you don't quite know what is causing, or even if they have no symptoms, it's important for the healthcare worker to be thinking, have I excluded syphilis? One of the reasons why public health is so concerned about syphilis is because of the risk of transmission to the baby, and that can have quite devastating effects. So in infectious syphilis, the rate of transmission is actually very high. So in primary to secondary syphilis, the rate has been shown in studies to be as high as 90%. And the rate of mortality and morbidity in the affected infant is also very high. So the mum can miscarry the pregnancy, the fetus can die in the uterus, it can die as a newborn, and if it survives, there are high rates of complications affecting many different organ systems. So this picture is taken from a case study that was published in The Lancet in 2020 that we have received permission to use the photograph of. The parents have been very encouraging for us to be able to use their case as learnings for other people, and this happened in the Netherlands. The key takeaway really is that congenital syphilis is preventable. If mum is treated more than 30 days before birth, the risk to the baby significantly drops. So this isn't something that shouldn't be happening, and it is terrible that we are seeing it happen across the state. So these are some of the numbers that we've seen across the state from 2020. I think we all maybe were a little bit, what's the word, heartened in 2024 when we didn't get any more cases of congenital syphilis. And sadly, we've had 3 cases already this year, one in the Pilbara, one in the Goldfields, and one in Metro Perth. Looking at the number of cases who were Aboriginal versus non-Aboriginal, again, you can see that Aboriginal people are overrepresented. It's terrible, terrible statistics. Yeah, that's terrible. So again, looking at our context here in Perth, we've had 12 cases since 2018, and 3 of those little babies have died. 10 of those mothers did have some point of contact with a healthcare provider, so they had some antenatal care. 4 of those cases did not receive syphilis screening, and that might have been because the form wasn't given, or the form was given but the syphilis was missed, or the form was given and the syphilis was on there but the mum didn't sort of follow through with the screening. 6 of those cases, however, actually were negative for syphilis on that first check when they have their bloods. That has then led to us revising our maternal screening to making it standard for women to be screened 3 times in pregnancy. This was, of course, already existing in Kimberley, Pilbara and Goldfields, where they have standard screening at 5 points, so additionally at birth and at 6 weeks postpartum. But this was quite, I guess it was quite groundbreaking. There was a lot of pushback about, you know, how much this was going to cost, whether this was going to be acceptable to women. Should we just do a risk-based assessment of testing? But, you know, how often do we know whether or not a woman is at risk? We don't know. She might not disclose, be willing to disclose her sexual behaviours. She might not know what her partner is doing. And so it, you know, really felt like it was less stigmatizing to make it routine across the board, to make it at the timings that they're receiving other tests anyway. And we have picked up cases on that sort of 28-week screening. So we feel like that introduction of this screening has prevented congenital syphilis. It is wonderful now, of course, to see that this recommendation has been adopted nationally, and so it's being rolled out into the national pregnancy guidelines as of this year. So what do we do for syphilis testing? These are our 2 mainstays: serology, where the lab will do a syphilis-specific antibody test first, and then they will do, if that's positive, they will do an RPR looking for disease activity, and that's expressed as a titer. You might have seen 1 in 1, 1 in 4, 1 in 8. If they have any lesions, then taking a swab of that for PCR is going to be really helpful, but you do need to write syphilis PCR on there, because not all labs will automatically do syphilis. If you ask for just like a genital ulcer kind of panel, they might only do herpes and zoster. You can see an example of a result here. So this is a syphilis serology result has come back. The initial antibody test is detected. They always do a second confirmatory test, which is also positive, and then they do the RPR, which is 32, or sometimes it's expressed as 1:32. And that's useful for us to get some indication of what's happening with the infection. So let's say this person was 1 in 32. It looks like they probably have active syphilis, but you do have to check the history to make sure that they didn't have a higher RPR previously, already treated, and that's actually coming down. Of course, if they have a very low RPR and they can't tell you whether or not they've ever had syphilis or whether or not they've ever had treatment, you need to try to figure out whether or not this is new and about to rise, whether this is previously treated, or whether this is old and it's never been treated at all, because that RPR will come back down over time as well. So this is quite a handy graph to have. I've heard ED doctors tell me that, every time they come across a result, they still have to pull out the graph to, help them to interpret it. It can be very tricky. You can always, of course, call your friendly clinical microbiologist, sexual health physician, or public health unit for help with interpreting that. Any questions before I keep going? No? If we do detect syphilis, then we're wanting to initiate treatment, and it's important to note that treatment is with this long-acting depot-style benzathine benzylpenicillin and not the short-acting benpen that we normally give. So oral and IV sort of short-acting benpen is not suitable. For infectious syphilis, one dose is 2 pre-filled syringes, stat, given simultaneously if possible, because it's quite a painful, uncomfortable injection to give. So if you have 2 people giving it at once, that can be quite helpful for the patient, but also stops the patient from getting up after the first one and running away, which has happened. If they have non-infectious syphilis, we actually want the antibiotic levels to be sustained in the body for longer. So they need to have 3 doses 7 days apart, which obviously is a hard sell, but again, necessary to prevent congenital syphilis, but also to prevent tertiary syphilis down the track. We encourage GP practices to keep the benzathine benzylpenicillin stocked because you can order it through the prescriber bag. We all know that there has been a lot of issues with the supply of benzathine benzylpenicillin. There is a worldwide shortage. There are alternatives available. They can be all ordered as well from the doctor's bag. So just kind of keeping on top of that, what is possible to get at that time, whether or not you need additional instructions for the alternative products. Some of them have to be reconstituted. Some of them resemble more this Bicillin brand. So kind of knowing that ahead of time and being prepped is also quite useful. And we discourage giving prescriptions because they're not commonly stocked in community pharmacies. Okay, additional things to talk about with your patient: if they're a child or woman of childbearing age, making sure that they're not also pregnant, checking that they don't have any other symptoms. If they do have, I do have an ulcer, actually, it's good to swab that. If they have neuro symptoms, need to refer because management changes for that. Caution them that after you give them the treatment in infectious syphilis, they might have some unpleasant side effects. So they might feel feverish, they might feel flush, they might feel dizzy, and that's just because all the little bacteria are being burst open, for want of a better word, by the antibiotics, and the bacteria bursting open releases things that the body reacts to, so cytokines, inflammatory agents that then make the body react, and that's why you get this reaction. So it's not actually that they're allergic to the penicillin or that this is a harmful reaction. It's actually the body fighting the infection, and with some paracetamol, some fluids, some rest, it actually improves by itself. You want to repeat the serology the day that they're treated. Again, remembering our RPR curve, you want to catch that RPR at its height. You want to start contact tracing, and you want to tell them not to have sex for 7 days because you don't want them to become reinfected. You want to catch the RPR on the height because you want to compare that RPR when you do their bloods again. They're going to be antibody positive from here on. So that's not going to tell you whether or not the infection is treated or not. We're actually looking for that RPR to fall. We want to see it fall by 4-fold. So if it starts at 1 in 8, we want to see it come down to 1 in 2. If it starts at 1 in 64, we want it to see it come down to 16. 64 divided by 2 divided by 2 again. Any questions? No. So this is where, talking to your patient, it becomes very important, particularly when it comes to making sure that we can get adequate contact tracing, making sure that we can get them back for follow-up. our public health unit developed this kind of simple English resource to talk to women about. We also developed this flyer with some more confronting images just to educate them that this can be quite serious, and this is why we want to make sure that we do the contact tracing and the follow-up really well. If you guys would like to use this resource, we can certainly send it on. As mentioned, we have a team here that consists of myself as well as a public health physician, clinical midwife specialist, clinical nurse specialist, Aboriginal health workers, and epidemiologist. Why I'm introducing you to our team is because I'm going to start talking a little bit about some of the ways, apart from encouraging testing and treating, that we're trying to prevent congenital syphilis. And our project officer. Sorry, Asha. So we have a syphilis in pregnancy program. We also have sort of enhanced surveillance looking at complex and priority populations, so people experiencing homelessness, people who use drugs, sex workers, anyone else who's proving quite challenging to follow up. We engage in education. So I showed you, one of the resources that we develop, but we also educate GP practices, hospital units, forums like this. And we think about how we can improve and work better in this space. So our syphilis in pregnancy program involves actually a whole panel of experts. So we have people representing all the antenatal units across the public antenatal units in Perth. We have sexual health physicians, we have representatives from obstetrics, pediatrics, neonatology, primary health, Aboriginal health, clinical microbiology, and us. So once a month we meet and we discuss sort of case reviews of women who have been diagnosed with syphilis in pregnancy, and we discuss things like, their treatment. Has their treatment been adequate? Do we need to repeat a course of treatment? We discuss things like their contact tracing. We hear from midwives who are talking to them on a regular basis. Do we feel like their contact tracing is adequate? Do we feel like there is a reinfection risk? We look at their results. In a previous slide, I had written that we normally follow up in 3, 6, and 12 months. In a pregnant woman, we might not have the luxury of that time. So if she's treated at, say, 24 weeks and 6 weeks later we get an RPR back that hasn't fallen 4-fold, it's only fallen 2-fold, is that, are we happy with that? Is there any chance that she could have been reinfected? Do we need to treat her again? So we sort of make a management plan and coordinate that with all of her caregivers, and that might actually be several caregivers. There might be primary health, might be a hospital, might be caseworkers, so kind of coordinate all of that. We also, as the pregnant person approaches birth, start to think about planning for the time of birth. So we look at what kind of plan we need to put in place so that the team looking after the woman and the team looking after the baby all know what tests and treatment need to be instituted. Now, so why do we do this? Why do we have these maternal neonatal management plans? It's because it can be difficult to know whether a mum has active syphilis at the time of giving birth. The changes in blood tests can take time and might not reflect the fact that a woman or a pregnant person has been reinfected recently. If the baby does have congenital syphilis, there may not be any features. So even though I outlined a number of consequences that congenital syphilis might have on a baby, studies from the past have shown that in many cases there are no symptoms at all. So we can't always rely on that to tell us whether or not a baby has congenital syphilis. Why don't we just test all babies? Unfortunately, sensitivity of testing in babies for syphilis is not very accurate as well. So if we can't rely on these things, what else can we rely on? And I guess for our women that we know might be at risk, we look at that risk assessment, again, looking at adequacy of contact tracing, looking at their recent testing results, and determining as a group with sort of everyone around the table whether this is a no risk, whether this is a low risk, or whether it's a high risk kind of situation. And then from that, we create a plan. The recommendations are based off the CARS guideline. It's a statewide guideline, and that's then disseminated to our antenatal birthing units, to the obstetrics department, to the neonatal department, and PCH is involved in this, so they sort of also are aware of this kind of plan. And that way, at the time of birth, hopefully it's very clear to obstetrics what they need to do. It's very clear to neonates what they need to do, but also when they call PCH to kind of just flag that this has happened, PCH also know what's going on. And this also serves as a good baseline in case there are any changes. Maybe you go to deliver the child and you notice some perineal lesions, or you go to examine the baby and there's some flag that something's not right. This gives us an opportunity to know what the risk level was sort of prior to birth, but that can definitely change at the time of birth, and then the recommendations will be adjusted accordingly. And it might go the other way as well. It might be that we thought someone was high risk, but then when birth and the initial investigations show that, are all reassuring, and then we can downgrade the management plan. So we do this usually at the start of the third trimester. So we try to get it done after the 28-week serology result is available. We did do it later, but then we were finding that many of our women were giving birth early, and we know that preterm birth is a risk of congenital syphilis. So now we get that done earlier, and sometimes if we're not sure where a woman is going to birth, then we'll send it to both services. Any questions about that kind of process? I wanted to really highlight the work of our Aboriginal health team, and I've taken this slide from the leader of our Aboriginal health team. So thank you, Naomi, because I think what they do is also really, really important towards preventing congenital syphilis. So when we do have someone who is pregnant and been diagnosed with syphilis and is Aboriginal, they will often be looking at some of the background of this woman, thinking about best ways to contact her, best ways to reach out to her, and best ways to sort of think about her care. So I'll illustrate this in a bit of a case study that has been de-identified. So an Aboriginal woman who presented late in pregnancy, and syphilis was newly diagnosed. She was unable to be recalled for treatment by the requesting service, the service that's kind of requested the syphilis serology to begin with, and the rest of the antenatal tests. Multiple agencies ended up trying to make contact with her. We knew that, at 33 weeks with syphilis, she could have the baby sort of imminently. So we created a plan, sent them to the places where she might potentially birth. Meanwhile, our Aboriginal health team was getting to work and found out really that this woman was very overwhelmed. New pregnancy diagnosis, new syphilis diagnosis, already had children. It's a lot, right? One of her children had an upcoming birthday that she was trying to organise. She couldn't just get up and attend appointments because she had these other children to look after. She had some court issues that were stressing her out. And so
Grace, are you there? Can anyone hear me? Have we fully lost it? I think I am. Hang on. What is going on here? You can hear me, but you can't hear Grace. I don't know if that's just cut Grace off there. Hang on. Allow camera, disable mic. Hang on, disable mic. Why is that?
Sorry.
That's okay. Grace, we can hear
Gosh.
you. Good, great. That might have been something to do with the end of the meeting or something. It might have had a bit of a freak out, but we'll get straight back into it. Let me just come back.
Can you still hear me? Okay. What was the last thing you hear me say?
She was very busy organising a birthday party and
Yes,
yeah,
yes.
kind of started to lose it after that.
Okay.
Thank you.
Thank you very much. Yeah, so our Aboriginal health team actually coordinated the whole sort of approach. So, you know, kind of said to certain services, you guys don't contact her, you know, said to another service, she has a good rapport with you, you guys contact her. So they coordinated the whole response, they organised transport, they organised childcare, and it was a really good result. You know, the lady was able to come in to be treated, and the babies did not have congenital syphilis. So that was a really good, good outcome. Okay, so you know, a few reflections from my time with the Syphilis in Pregnancy program, and having been a part of countless congenital syphilis reviews. I've lost count how many I've been a part of, is that there is still a lack of awareness to test. It's even though syphilis has increased, it's still not common. So we still have a lot of people who will just test for chlamydia and gonorrhea, or they'll ask the patient to test and the patient won't, you know, proceed with a blood test because they don't think that that's a big deal. So I think we're still seeing that could be improved, people's awareness of test. The other thing is ulcers, being able to swab for an ulcer PCR for syphilis is relatively new, so a lot of people don't know about that either. They will test for HSV, for herpes, but not for syphilis. So these are some things that, you know, we want you guys to continue spreading the news about. And then when to test, again, you know, the pregnancy screening guidelines are relatively new. Outside of maternity hospitals, there's still not huge awareness about it. And again, you know, just trying to remind people to exclude syphilis. Fragmentation of care, so people who, so, you know, we had a woman who presented to a GP because she was in the area and she was late in pregnancy, but that GP didn't know that she, you know, had seen a GP previously but not gone through with her blood tests and had been referred but not actually been to antenatal care. You know, like they don't see an overarching view, and it doesn't help when GPs are only incentivized really to have short consults and to then bring the next person in once this particular issue is dealt with. They just kind of bring the next person in. So yeah, across the board, there is a lot of fragmentation of care, and I'm sure you guys experience that as well. And I think, you know, that is a role that we do play in our syphilis response team to try to bring agencies together and improve some of that communication. The need for culturally safe care and different models of care. I think this is a huge need for Aboriginal people, and to be able to meet them where they are, and to, yeah, I don't know how to make a dent in this, but apart from Aboriginal people, you know, we've had a number of cases of congenital syphilis in culturally and linguistically diverse populations as well, and you know, there's certainly a paucity of culturally safe and appropriate care for them as well. Contact tracing is resource intensive but critical. And this is where, you know, it can differ from chlamydia and gonorrhea, where often that conversation in GP practices can be just like, oh yeah, you know, I'll let them know, don't worry about it. In syphilis, and particularly when we've got a pregnant woman involved, really trying to get down to that to prevent the reinfection risk and to stop the onward transmission is so important, but requires, yeah, a lot of resources. So that's kind of all from me at this stage. Does anyone have any questions?
And I do think this webinar has somehow muted and turned cameras off. So maybe just pop your hands up, beautiful, and I will unmute and allow. Yeah, let's just have a look. Allow mic, beautiful. All right. And Gary, sorry, it did start at 12:30. We have run over just a little bit here.
I think Suzanne has her hand up.
Yeah,
Can you
so
see that,
just try and can you unmute your mic there, Suzanne? Lovely.
Okay. Yeah, thanks. This has been really great, informative, and interesting too. I just have one question. You know, the quick guide for testing and treatment of syphilis infection in WA, this one? Does anyone, that one?
The brown one.
Yeah, that one. I just realised that on there it says benzathine penicillin. It doesn't actually say benzathine benzyl penicillin. So is that okay? Is that going to be updated to reflect the bacillin LA, or I know this one's, yeah.
Yeah, I have to say that often it is referred to as benzathine penicillin, and that's probably even slightly more helpful because the short-acting penicillin is often referred to as benpen. You know, they
Okay,
both actually have benzyl penicillin in their name,
yeah,
but this has got the added benzathine, which is the, yeah, indicates the long-acting formulation.
Okay, so that's still, yeah, okay, quite relevant. Thank you.
Thanks, Suzanne.
Any other questions? No worry, Nina. Thank you. I do have a quick one, Grace. I was just wondering, I suppose, like with near miss cases, how they are defined and how that sort of comes about. If I don't know if that's a quick answer or a long answer.
A near miss case is where a woman could very well have given birth to a child with congenital syphilis, but by a miracle, the baby does not have congenital syphilis. So mum had active syphilis at the time of birth, or she was treated less than 30 days prior to birth, but the baby didn't have congenital syphilis.
Right. I did wonder that, and I think sometimes even from previous nursing, you're just like, how did that baby not be born with congenital? Like it's mind blowing sometimes when you're catching women quite far down the track. Yeah, it's so lucky. It's so lucky, I think.
It's lucky for them, but an
Yeah.
opportunity for us to still look at what happened.
Absolutely. Beautiful. Great. Any other questions? I think we're looking pretty good there. I'm just going to quickly pop a little link in the chat as well. That's just for a bit of feedback if you have time. Otherwise, I think we'll probably call it there. Grace, what do you think?
Thank you very much for having me.
Thank you, and thank you everyone again for helping and dealing with the technical difficulties. It's you know, we get through it.
Thank you.
All right, thanks everyone. We'll see you soon. And thank you. Have a good day.
Bye. Thanks.
Anything else you wanted to